Hello, greetings everyone. Good evening and welcome to the fourth day of orthodontic MCQ solving with Dr. Krishna Priya. Hi, I'm an orthodontist and I'm here in this platform to provide you with all the information regarding various concepts to clear NEET MDS 2020. So anyway, let's proceed. So as a thumbs up, I gave an idea of the topic that we are going to discuss today. So it is mainly about the orthopedic appliances. So initially we'll be starting with the concept wherein I'll be discussing all sorts of MCQs which may arise from the concept, and then we'll be going to the questions. If you have any doubt in the middle, or you can post your questions in the comment section so that we can address to it later. Okay, with that note, let's start today's session. Yeah. And I'm just confirming that. Is my slide visible? Okay. Okay, done. So we are going to see about orthopedic appliances. So what are orthopedic appliances? So generally, orthopedic is associated with an extraoral force or attraction which is applied to the face, which is an adjunct towards the orthodontic treatment. So everyone would be having a weird or vague idea of what orthopedic appliances are. So generally, headgears comes under this concept of orthopedic appliances. So don't worry, headgear is not such a big topic. Okay, if you break it down to small segments, then you can definitely have a thorough understanding of headgear and answer all the questions which comes from it. So in the first 5 slides, we'll be seeing about different types of headgear, how they are classified, and what actually happens when a headgear is given to the patient. And I really stress on this point because the initial 10 minutes of the slide will give you enough concepts and will make you understand the idea behind headgear, with which with this knowledge you can answer a lot of MCQs when it comes under orthopedic appliances. Okay? So coming to classification, headgear can be classified according to its area of attachment. So what is headgear basically? It is an elastic band which we use the extraoral face as support to connect it to the intraoral area using a face bow. So here you can see a picture which demonstrates there is a neck band or an elastic strap which is connected to the outer bow. The outer bow is in turn connected to the inner bow. In the inner bow, we'll be engaging it to the fixed appliance of the orthodontic treatment. So an extra oral traction of force is applied to the intraoral through a support. So depending on the area of the support that is gained, it is classified into cervical area. So when the neck band is here, it is cervical area of the neck, or else occipital area when it covers this side, and chin cup can be used, or else frontal or reverse pull headgear when the support is not taken from the dorsal side but instead the ventral side, the front of the face, then we call it as reverse headgear. Or we can also go for combination wherein we need the force to travel in this direction, so we take the support of both occipital and also the cervical. So when we give both elastic strap, the resultant force will travel in the direction which is common to both. So it's called as combination headgear or a very high pull headgear. In that case, the elastic strap is given a bit above the occipital, that is parietal, so it is given here, that is the high pull headgear. So always imagine wherever you are getting support from, right, the associated bone will be the area of classification: cervical, occipital, or high pull or combination headgear, chin cup or reverse pull headgear. So it's very basic. So these are the different classifications of headgear. So according to how they are used, it can either be retractors or protractors, right? So for protractors, that is in the front part of the face, ventral, it's called reverse pull headgear. It does not help in the retraction of the anterior tooth, but instead it tries to bring the maxilla segment forward. Retractors will have the remaining segments of headgear classification, which includes high pull, straight pull, cervical, or combination. To control the vertical excess, chin cup is used. Chin cup also needs the support of an extraoral area that is behind the head, so that chin cup also comes into this classification. So all these areas based on the usage comes under the growth modulators. Headgears are generally used for children whose growth direction can be modulated. But this headgear can also be used in adult to for certain conditions like space regaining, molar distalization, and intrusion of maxilla as such. So as we were discussing previously, when it came to the absolute anchorage, okay, we use stats wherein we intruded a particular tooth or two tooth associated with it. But when we are trying to intrude the whole maxilla as a segment, then we would use an extraoral traction of force, that is headgear, to achieve the same. Okay, so this slide was very important. We should understand what is the classification of headgear before going to answer the MCQs. So here you can see the first one is parietal pull, that is it is quite high to the occipital, so it is called as high pull headgear. And the second one is cervical pull, and the third one is occipital pull. And in all these three you can notice the direction of the force. Okay, so basically what headgear does, it takes extraoral support, and there are two bows associated with it. One is inner bow. This inner bow is connected to the maxillary molar headgear slot. There are three slots there. So the inner bow will go into the maxillary molar headgear slot, and then this inner bow is connected to the outer bow in this area, as you can see. I'll just take a pointer and mark it for you. Yeah. So in this area, and then the outer bow is taken at a particular angle, and using an elastic band or e-chain or some force modules, right, it is connected to the elastic strap, so that this angle of the outer bow with the inner bow maximum decides the direction of the force, resultant force. So since in cervical it is more of a downward direction, so whenever we wanted a downward direction of force, then we can go for cervical. Or if we feel that the patient's height is excess, so we need to intrude the maxilla, then we have to go with the direction of force which is more vertical, that is above. So if you understand this concept, then everything is a cakewalk for you. As I already mentioned, so depending on the area of attachment, the headgear is classified, right? So what happens basically, so this is the area wherein the inner bow is getting attached, and it is making an angle with the outer bow. The outer bow is made in such an angle that it is positioned at the center of resistance of the whole maxilla, so that it undergoes a translation. So before going into this concept, what is center of resistance? Okay, for that I need to take an example of a phone. Okay, this is a phone. So the center of resistance for this phone is in the middle. Okay, so if I'm putting force in the middle, then the phone will go up like this. But what if I put a force, or if I place it in whatever direction which is not the center, then what happens? It rotates. It either rotates in this direction or this direction. So only when you put force in the center, it goes as such up and as such down. So this is the center of resistance of the phone. When it comes to the tooth is in a three-dimensional space which is occupied by the bone, by gingiva, and also by the crown as such. So the center of resistance varies from each tooth, and it also depends on what area of segment we are considering. For example, for molar individual tooth, the center of resistance is marked here. But when you consider the whole anterior segment, that is from canine to canine, what is the center of resistance? Then that would be between the lateral incisor and canine. If you consider the maxilla as a whole, the center of resistance would be somewhere in the pterygomaxillary fissure. So, depending on the area, the center of resistance varies. So, this outer bow will help in identifying the center of resistance and will go closely towards it. For example, see, if the center of resistance of the whole maxillary segment is here, then see the outer bow is going close to it, so that when we provide the force from here with the support of our extraoral feature, then what happens? A translation of the whole maxillary segment happens. So only we can't go in the intraoral region, because we have to penetrate the bone or penetrate the buccal mucosa. That is very difficult. So that's why we have an inner bow and outer bow, and a particular angulation between them, so that we target the force at the center of resistance. Thereby, the maxilla will move as such in a translation. What will happen if the entire force is passing below or above the center of resistance? Obviously, rotation will happen. But we can even use it to our own advantage. How? Whenever we want a downward rotation, we can take the force which is almost downward to the center of resistance. So obviously, since it's downward, they'll have a downward rotation. What will happen if the patient is already a long phase, okay, and we need to have an upward rotation or an anti-clockwise rotation? Then we take the force which is superior to the center of resistance. So we just play around the center of resistance with what? With the angle between the inner phase bow and the outer phase bow. I mean, inner and the outer bow. So I think with this knowledge, you can play with a lot of questions. But it will be a waste if you don't understand this concept before attending questions. That's why I'm taking so much time to explain what is center of resistance and what will happen if the force is not passing through it, and what are the different types of headgear and how it is associated with each area. See, so as I mentioned, the center of resistance is here. And according to some literature, how we can identify the center of resistance is we take an FH plane. So this is an orbital point in the cephalogram. And we take a functional occlusal plane. So these planes are almost parallel with each other. So at a point which is distal to the first molar, we draw a perpendicular line. Okay. So where it meets in half will be considered as the center of resistance of maxilla. It can easily be identified in the extraorally in this area. So whatever we do, if we want a translation of maxilla as such behind, then we try to position our outer bow in such a way that it is in that point, and the resultant force acts in the along the direction of center of resistance, thereby taking the maxilla with it. So I've just given a lot of examples for you to understand how it is done. As I said, for molar, the center of resistance will generally be in the furcation area for a particular tooth. But when it comes to the maxillary segment as a whole, the center of resistance varies. So don't confuse with a segment of the tooth or a segment of maxillary component as such. But instead, imagine whatever the tooth it is, the center of resistance will be a resultant of the centroid points drawn, and it will be in a particular area. If the outer bow or the force pass through the center of resistance, then we can definitely undergo translation, or if not, it will have a rotational movement to it. So these are the examples. What will happen if we go above or below the center of resistance? We'll have a simultaneous rotation which is above or beyond. So this diagram explains it so clearly. So what is this? Till now we were discussing about headgear, which is a cervical support or combination or an occipital support headgear. But what happens in the protraction phase, protraction headgear, or it is also called as face mask? There are two types, like Delaire or Petit type. So we'll be discussing about those two later. So what happens and why headgear is used for protraction? So basically, they take support from our forehead and also the chin. Okay, it is customized for the particular patient, and the screws are being tightened. And then what will happen here? Also, they'll have an inner and the outer bow. So as you can see, right, this is the outer bow which is connected to both the edges of the mouth, and they'll have an elastic band which they can wear from the inner to the outer bow. This is generally used for protraction of maxilla. So early in the class 3 cases, the maxilla would be behind the mandible with the patient having reverse overjet. So in order to correct it, they want the maxilla to come forward. Usually the maxilla would be collapsed, or it will be constricted and it will be positioned backward. So when we bring it forward, we also need to expand it. So generally, this protraction face mask, it is associated with an expansion device intraorally. They also have some hook in the B, in the picture B, as you can see. They'll have this hook. So with this hook, they'll connect to the outer face bow in a particular angle, so that the maxilla comes downward and forward and it's getting protracted. So this is the concept behind the protraction face mask, and generally it is between 15 to 30-degree angulation, because we want a downward direction of the maxilla. So with this I'm completing the concept. So we've known different types of headgear classifications, and what is the center of resistance of maxilla and how we can achieve translation. What will happen if we go above or below the center of resistance, and what is rotation, what is a protraction face mask. So we've covered everything, and now we quickly go over the MCQ. So, on the occipital pull headgear. So occipital is here. If the force is inferior to the both the center of resistance of maxilla and the maxillary dentition, what will result? So without seeing the answer will confuse you. What will happen if it is below, right? Then there will be a downward rotation. So the answer will be posterior clockwise rotation of maxilla and posterior clockwise rotation of the maxillary dentition. So as I mentioned, for maxillary dentition, the center of resistance is different. For maxilla, it is closely near the pterygomaxillary PTM. Okay, yeah. See, so as I mentioned earlier, so see, for maxillary dentition, it's here. For maxilla, it is here. So when the given force which is below the center of resistance of both maxillary dentition and the maxilla, then we'll have a downward rotation. So it's very simple as that. Face mask is used to provide. So just now we saw face mask is nothing but reverse pull headgear. It is given in the front. So dorsal means back and ventral means front. So obviously the answer would be ventral. Ventral refers to the front part of the face. So yeah, generally the face mask is given in conditions wherein class 3 is majorly expected, and that too it is given along with the expansion appliance, and it is only given in patients who are in their pre-pubertal growth spurt. Why? Because for everyone the maxilla would form way before the mandible. So when they are around the age of 6 to 7 years of age in male or female, so the face mask is indicated way early before the closure of the palatal sutures. So basically, maxilla is a fusion of two bones, like palatal bones together, right? So it will also be helpful in the expansion before the sutures like interdigitate properly. So we can also expand and bring it forward. So the success also depends on various factors like patient's age, growth pattern, and compliance. Because patient need to wear the elastic regularly for them to appreciate any protraction. If the patient is not compliant, because it's very difficult for the patient to hold on for a really long period of time at a very young age. So we have to take that into consideration. Done. The next question. Correct direction of class 3 traction elastics during the use of face mask therapy. So as we've mentioned, it is from the hook which is present intraorally to the outside. What we need a downward and forward maxillary protraction. Elastics with 10 degree above the occlusal plane or parallel to the occlusal plane, 15 to 20 or 30 degree. So what will be the answer we've discussed just now? So it is 15 to 20. Okay, there are a lot of researches and studies which support this theory. So the face mask is also known as reverse pull headgear or delay mask therapy. So there are different types of face mask which is used for a separate condition. Either it is for a broader face conditions or a vertical control condition. So we'll discuss that later. The direction of traction elastic is important for achieving the orthopedic effect. Orthopedic is nothing but growth modulatory effect. So the specifically it should be around 15 to 20 degrees to the occlusal plane. Why? Because the downward angulation signifies the maxilla to come downward and then forward, promoting the desired maxillary growth. And also we exert a pull force on the maxilla, which will enable the bone also to form. Thereby, we have a bone formation around the maxilla and will be stable for a really long time. And they also help in aligning the force vectors with the desired orthopedic effect, therefore resulting in a most effective treatment outcome. So yeah, I've said remaining things. The following instrument is used for the advancement of maxilla is known as what? So this is not a McNamara appliance, obviously. So this is not a high pull headgear because it is given in the forward. It can either be Delaire face mask or Pettit face mask. So this answer is Pettit face mask. So the Pettit face mask is the one which is in downward, and Delaire face mask is the one which is above. So Delaire is basically taking support, and it will be in a horizontal direction. So the center line, it won't be in the central. Okay, they've taken support from the either side, that is lateral to the face is Delaire, whereas Pettit is in central to the face. So this Pettit face mask is generally used in class 3 correction, where the lower jaw protrudes forward relative to the upper jaw. So that is class 3. The class 3 can be either skeletal or dental. See, what is class 3? It can either be because of maxillary retrognathism, that is the maxilla itself by skeletally it is behind, but the mandible is normal. Okay, that can also be class 3. Or It can be maxilla is normal, but mandible is very much protrusive. That can also give class 3, or it can be a combination of both. So we must first identify whether it is a skeletal class 3 before proceeding with the face mask therapy. And also, if it is a skeletal class 3 and the patient is in growth spurt, we can definitely go for face mask, or else if it is an adult case, then they have to look into the extraction scenarios, decompensation procedures for surgery, and such, and other modes of treatment. But this face mask or a growth modulation can only be supported when the patient is under the prepubertal growth spurt. So some of the facts is that the petit face mask is one of the appliances used in the maxillary advancement treatment. So for maxillary retrognathism, it is most preferably used. The direction and magnitude of forces exerted by the petit face mask are also determined by the individual patient's needs and the growth pattern. So, for best results in class 3 malocclusion correction, the orthopedic appliance should be worn for at least, so they would definitely go for about 12 to 16 hours per day. Okay, that is the ideal amount of time that the patient should wear in order to get some bone deposition or growth modulation effect. 12 to 16 is an ideal time, kindly remember it. So patient in mixed dentition stage, he has class 3 malocclusion with open bite. So SNA is 78, SNB is 82, he is treated by. So these are some clinical conditions. So I'll help you how to delineate this. So the first key factor in the question is mixed dentition. So the patient age is less. Mixed dentition, they may be below 12 years. So they may be around 7 to 10 years. So that is the first key point. Second, he is a class 3. So he may be requiring a face mask because he is in the prepubertal growth spurt. So his SNA is denoting the maxilla. So if this is the cephalogram, right? So this is the A point. This is the A point and this is the B point. B point is in the mandible and A point is the maxilla. And so this will be the N point, right? So this SNA and this is the S1. So what they'll generally do in Ceph is that they'll connect the SN to A, okay, and also they'll do SNB. Usually SNB should be lesser than the SNA, but in this case, since it's a class 3 condition which is skeletal, the SNB is greater than the SNA. So all these give us the fact that the patient is under the pubertal growth spurt, okay, and he's a skeletal class 3, and they've also given values, and the patient has open bite. So what will you do now? Obviously there will be a reverse pull headgear, but what happens, they have a vertical pull chin cap and a reverse pull headgear. So why they've given vertical pull chin cap? Because already the mandible is growing faster, they want to control the vertical growth. Why they are going for the vertical? It means that the patient is already giving the condition of an open bite. So generally in open bite, as we discussed in habits, the lower anterior facial height will be increased. So in order to reduce the vertical dimension, they are going for vertical pull chin cap along with reverse pull headgear. Reverse pull headgear, the conditions are mixed dentition, class 3 and the Ceph values. So we have to accumulate it and then look at the answers. So in these conditions, you can even neglect the answers, like you can't go for cervical pull headgear or vertical pull headgear because you need a forward protraction of the maxilla. So between this vertical and horizontal, the open bite is the keyword for you to discuss what is what. So they've just given. Additionally, obviously, after a protraction face mask, they have to undergo an orthodontic treatment for the correction of the alignment. So next question, high pull headgear is used to. So now we are talking about headgears. So headgears is something which is used for the retraction of the anterior or maxilla as such. And they've used the term high pull. So something which is associated with the long face. So what will happen? Extrude the maxillary incisors and correct the anterior deep bite. To intrude the maxillary incisors and correct the anterior deep bite. To intrude the mandibular incisors and correct the anterior deep bite. So here we can definitely eliminate two options. So none of the above is wrong, and it doesn't even make a difference on the mandibular incisors. So either it extrudes the maxillary incisors or intrudes it. So what will be the correct answer? It will be B. Why? Because the direction. See, as we said, high pull headgear. So high pull headgear is something like this. So since the outer bow is very much close to the center of resistance, For him, since it's a high pull, the center of resistance may be somewhere around here. So it will be above the center of resistance. The force directed is above. So what happens? Intrusion takes place. It goes up. There will be a rotation wherein an intrusion takes place. So here the answer would be to intrude the maxillary incisors and correct the anterior deep bite. Yes. So usually in class 2 cases, it is associated with the deep bite, and headgears are used for class 2 cases. And protraction face mask or protraction reversible headgear is used for class 3 cases. So remember like that. It is not always, but most preferably 99% of the cases. Hypal headgear is used for correction of anterior deep bite because it intrudes and retracts the maxillary incisors, which means that it moves them upward in the bone and then backward within the arch. It is all based on the position, the resultant force with respect to the center of resistance of the maxilla. Done. So always remember, hypal headgear always gives an intrusion of the maxillary incisors, and also it retracts it possibly. When we talk about a combination pull or cervical pull, we have to think about extrusion. Basically, imagine for central incisor and high pull, central incisor and cervical headgear. That's all. A headgear applied to the maxillary molars can serve to improve the anterior posterior skeletal dysplasia by. So obviously headgears, the inner bow is given to the maxillary molars only. So what will happen? So here they have not mentioned what kind of headgear it is. So downward and backward rotation of maxilla or posterior repositioning of maxillary teeth within the maxilla, rapid palatal expansion, redirection of the maxillary growth. So the answer would be redirection of the maxillary growth. Why this answer is chosen? Because in the first option, downward and backward rotation, so they're not given which type of headgear is used here. It can either be high pull or cervical, so we cannot be very sure on choosing this as the right option. Posterior repositioning of the maxillary teeth, so what they mean is that translation of the maxillary teeth within the maxilla. This can also be right, but it is not so perfect to the question because they've not mentioned what kind of headgear they're going to be using. Rapid palatal expansion is like totally not related to the question, and redirection of maxillary growth, because headgear is generally an orthopedic appliance which will associated with the growth modulation. We want the growth to be modulated, so the best answer for this question will be redirection of maxillary growth. So whenever you feel that for a particular question it can have more than one good answer, then always go with the answer which gives the perfect situation or perfect answer to the given question, and not which is closely associated with it. We need more information to be specific. So some facts associated with this topic we'll be saying. So orthopedic force, it exerts pressure on the bone and the surrounding tissue and resulting in the bone formation. So that's what is the entire process of orthopedic or growth modulation is about. And it also in the similar way it will help in the positioning of maxilla and the desired location. What is functional appliance? So basically, you know what a functional appliance. So they are appliances which is used when the patient is in their growth spurt. Okay, when their bones are growing, or whenever the patient is in a skeletal class 2 or class 3, functional appliances like activator, bionator, frankel or twin block is given in order to correct their maxilla or mandible to an optimal position. So sometimes headgears can be used along with functional appliances in order to direct their growth in a particular direction. For example, if a patient has maxillary prognathism along with mandibular retrognathism in class 2, the twin block can be used to correct the mandibular retrognathism. They can bring it forward. But this maxillary prognathism can be stopped. The growth of maxilla can be stopped by giving a headgear. So usually in twin block, we also provide a fly strap so that we can attach the headgear option to it, and in this way we can restrict the growth of maxilla by allowing the mandible to grow. So sometimes when question comes like the patient gives a combination of class 2 wherein the maxilla is forward and the mandible is backward, then you can prefer you cannot only prefer twin block. So twin block plus headgear is also a good option for that question. Compliance and timing, that is very important. Multidisciplinary approach, yeah, obviously any child who presents with some complexity would have a multidisciplinary approach towards the treatment. So which of the following is not the function of the headgear? Anchor augmentation, distalization of molar, uprighting of molar for protraction of maxilla. So as we discussed earlier, it would obviously be uprating of the molar because headgear is concerned with the big area. So it can also be used as an anchor augmentation. If you don't want a particular tooth to move, you associate with the headgear. It will act as an anchor and stabilize the unit. It is also used in distalization of molar and but uprating of the molar it is concerned with a single tooth. So this whole unit cannot be used to target a single tooth. Okay? Protraction of maxilla obviously reversible headgear that is face mask. So uprating cannot be done because an uprating we generally give springs or brackets or tarts associated with a particular tooth to uprate it, and we do not include a headgear or an extraoral orthopedic appliances to do this function. The Clown effect is observed with appliance what? So this Clown effect is nothing that he designed a cervical pull headgear with certain modifications in the inner and the outer bow. So the answer is cervical pull headgear. So what happened is that he designed in such a way that the distal crown tipping was produced by positioning the outer bow of the face bow very close and below the center of resistance, and distal root tipping by the positioning the ends of the bow above the center of resistance. So he played with the positioning of the inner and the outer face bow so that they have a tipping of the molar tooth. So his separate modification thereby came to known as clone effect, and it is done in the cervical pull headgear. Okay, yeah. So the answer would be it is observed when a cervical pull headgear is used in the orthodontic treatment. He just made some modification. The intraoral component it includes balms or attachments on the molars, and the extraoral component is the headgear frame that connects to the intraoral component. So yeah. The effect is actually the maxillary molars, they are distally moved backward, and the resultant mesial movement of the maxillary anterior tooth. What he says is he's making sure that the maxillary molar is not coming forward when we move the maxillary anterior teeth back. What he does, he increases the anchorage by distally tipping the maxillary molars by incorporating some changes in the inner bow. Okay. So, what is the mechanism of action of cervical pull headgears? It provides a distalizing force on the maxillary molars because the cervical pull is down. So, it always provides a distalizing force, and this force is transferred to the molars using an intraoral component. As we already know, there is an intraoral bow and there is an extraoral bow. So, the force given to the extraoral bow is transmitted in turn to the intraoral bow, which shows its effects onto the maxillary dentition, which behaves in the similar way. So since it is below the center of resistance, obviously we can expect an extrusion of the maxillary molars, and as a result, they move distally and the anterior tooth are displaced easily. Cervical pull headgear is commonly used when there is a need for distalizing maxillary molars, and it can also be helpful in creating space in dental arch or correcting the anterior crowding. So why would we need to distalize the molars whenever they have a class 2? Okay, and they want the molars to be moved forward so that the malocclusion goes to class 1. And also when we need to correct the protraction, in such cases, distalization of the molars usually associated with the cervical type of the headgear. Main drawback of cervical headgear therapy. So extrusion of upper molars, intrusion of upper molars, extrusion of lower molars, and intrusion of lower molars. As we already know, lower molars do not have a big space in the headgear. It is associated with the maxilla as such. So extrusion of upper molar is the drawback as we discussed, right? Because it is below the center of resistance. So whenever they distalize it, obviously it's going to be extruded. So in order to counteract it, they do some things to prevent the extrusion. Yes. So because of the direction of force which passes below the center of resistance, extrusion obviously takes place. So it can lead to several problems. What will happen because of the extrusion of upper molars? There will be a downward and backward rotation of the mandible, which will in turn lead to open bite, and it is very unfavorable occlusal relationship, and it can also lead to anesthetic smile. So it is very important whenever we give a cervical headgear, we have to make sure that the patient is not already a vertical grower. So if the patient is already presenting with an open bite or an increased lower anterior facial height, then cervical headgear is a big no because it will in turn have a downward rotation. Whereas when we need a downward rotation of mandible, because the patient has a horizontal growth pattern, then it can be used in certain ways. So we have to be very sure on what type of headgear we give for a particular patient. Extrusion of upper molar is recognized as a drawback in cervical headgear therapy. All of the following directly result from cervical pull headgear therapy except opening of the bite, yes. Distal movement of the molars, yes. Inhibition of the forward growth of maxilla increases the forward growth of mandible. So, what will be the answer? It is D. That is except, because it is not directly associated with mandible. So, they confuse you saying all these answers, but usually headgears are directly connected to the maxilla and not directly on the mandible. They have an effect on the mandible, but they're not directly connected to the mandible. So increases the forward growth of mandible is really wrong. It may aid in the rotation of mandible, but not growth of mandible. If you're very sure on this, then you can definitely ace all the questions when it comes to headgear. So yes, it has a distal movement of maxilla because they provide a backward force which will in turn distalize the molars, and they inhibit the forward growth of maxilla because they don't pull the maxilla forward, right? Headgears is all about retraction of the maxilla. So the maxilla won't grow anywhere soon in the forward direction. It increases the forward growth of mandible. No, cervical headgear doesn't do that. Headgear, when properly constructed, can move a permanent maxillary first molar crown. Yes, we were just talking about it, that how it can distalize molars properly. In what direction is what the question is. So laterally, vertically, mesiodistally, and all of the above. All of the above. Because one of the side effect of headgear, while distal movement is happening, right? So what will happen? Obviously, it is going to extrude. So there is both a lateral movement, vertical movement, and mesiodistal movement. So mesiodistal is distalization, vertical is extrusion. So whenever in the maxilla, our alveolar bone is such a way that it is closer in the beginning and it extends in the later stages. So when the first molar goes distally, the arch actually expands. So obviously it is also going to go in the lateral direction. So since the molar is going to move in all the three dimensions of force, then here headgear actually, when properly constructed, we can play with what position we want the molar to be, and therefore the answer to this question is all of the above. Combination headgear is the marriage of. Okay, we've just now discussed it. So combination is nothing but something which is associated with the neck and something associated with the parietal bone. So what is the answer? High pull and cervical or occipital and cervical. So we have a close question. High pull and occipital is not an answer. Reverse pull with chin cup is also not an answer. So it's between A and B. So the answer is B. So high pull is something which is even beyond the occipital. It's very high. So manually, when it comes to combination, it is just occipital and cervical. Somewhere in between, we give it. Hypal is given in what cases? In cases where there is an excessive vertical growth of the mandible, and thereby we give in the parietal region. That is called hypal headgear to control the vertical direction, vertical dimension of the patient. So hypal and cervical, there are so many combinations that we can give, are two different types of appliances and used in orthodontics. High pull, it forces the upper jaw and the teeth in the backward and the upper direction. Yes, why? Because it is above the center of resistance, so it is more of an intrusion type. But cervical is kind of an extrusion of the molars because it is present below the center of resistance. So combining these two will result in a different configuration of the combination headgear. The action produced by both these headgears actually negate each other. So it will be in a different direction, but basically combination headgear is combining occipital and the cervical. Reverse pull with chin cup is given in the conditions wherein the patient is presenting with a class 3 and they need maxillary protraction, but they have excessive mandibular growth. So we chose this option as an answer for a different question, right? So only when they have an excessive mandibular growth, we want an open bite, we will give chin cup to prevent the vertical direction. Headgear applies force. So usually when it comes to headgear, it is always 200 to 400 gram per side. So this per side is very important. You should then for both, if the answer is given in both sides, then it will be double the amount. So 200 to 400 gram per side is the ideal amount. Reverse headgear or maxillary protraction is used mainly. Why? It's used mainly in the class 3 condition. Whenever we want the maxilla to come forward, right? So that is why reverse headgear is used. So what is the answer associated here? Retract the maxilla. No, we don't want to retract it. To induce the growth of maxilla in skeletal retrusion. To inhibit the growth of mandible. No, it is not associated with mandible. To induce the growth of mandible, no. So the answer would be B. Only growth of maxilla and the skeletal retrusion. So we actually addressed all the things given here. So the profile of the patient also would be mid-facial deficiency. So in those cases, we can use a protraction face mask, that is reversible headgear, to protract the maxilla forward. A face mask is used to treat what? Usually they're confusing you with telling mandible. Don't even think about it. If it comes to a headgear or face mask, it's always about maxilla. It may have an effect on mandible, but it is concerned with maxilla as such. Mandibular retrognathosum, no. Maxillary prognathism, no. Maxillary retrognathosum and mandibular prognathism. So here, since they've given it along with the mandible, the answer is C. It's maxillary retrognathosum to begin with. So before going to it, I'm telling you, understand the question properly. So this face mask or headgear, it is associated with growth modulation. The patient should be under the growth spurt. Especially with face mask, we need to start early. So this face mask is directly associated. The inner bow of the face mask is going into the maxilla, right? Usually, an expansion appliance is given in the maxilla, which will have a hook here, and from that hook, an elastic is given to the outer bow, which is at an angulation of 15 to 20 degree. Why? Because we want the maxilla to grow outward and downward, and then develop the bone in the posterior aspect of the maxilla. And with that, the mid-facial deficiency will also decrease. So this is the common concept behind face mask. Appliance of choice in cases with anterior-posterior maxillary deficiency. So there is an AP deficiency. Then what would be the choice here? Reverse pull headgear. Why? Because see, what they are telling is that the maxilla is deficient. That means it is retrognathic maxilla. So we want it to be increased. So we have to do something from the front end, ventral end. So it will always going to be reverse pull headgear. Only when the anterior posterior is excess, we need something to reduce it. So we need something from behind. So there only headgear comes into action. Deficiency is also a term which is used uh, in the place of retrusion or skeletal retrusion as such. So, dimensions of the inner bow of the face bow of headgear. So inner bow, that is the bow which is going into the buccal tubes placed in the maxillary molars. What is that? The answer is 0.45 and 0.125 inches round stainless steel. So these values you have to memorize. 0.45 into 0.125 in stainless steel. That is for the inner bow. The force delivered by the reverse pull headgear can be best described as. So, what is reverse pull headgear? It is face mask. So, it is present in the front of the face. And what does it do? It is actually pulling it. So, what do you mean by pulling? So, it's a tensile force. So, tensile, it is also present in the forward. So, it's tensile and ventral. So, if you just split the question into parts, then you easily get your answer. You don't need to worry about it. Just very easy and simple. If you understand the concept, you can answer almost all the questions. So tensile force is different from compressive force. Compressive force is used for headgear. You're just compressing it behind. But in tensile, you're pulling it out so that you can develop and you can make the bone formation to happen. So face mask already always has a tensile and a ventral combination. Chin cap is used to correct what? So chin cap is something which I've given in the picture. So chin cap is used for correcting the vertical dimension or vertical growth of the patient. So it is usually associated with class 3 malocclusion. As we already said, when the patient has a mandibular prognathism, usually in class 2, it is commonly associated with mandibular retrognathism. In such cases, the chin alone won't grow forward. So chin cap is generally used to reduce the mandibular prognathism and prevent the growth of mandible. Yes. So underbite of prognathism in class 3 alone, whenever there is a combination. So as I already mentioned, right, class 3 can be either maxillary retrusion, mandible is normal, but only the maxilla is retruded. Then you can use only face mask. Or in cases wherein the maxilla is normal and the mandible is prognathic. So in this case, you can use only chin cap. When there is a combination, then you can use a combination of both. So you should identify what exactly the problem is, based on which you can identify the apparatus which is used to treat it. All of the following is indicated in patient with midface deficiency except. Okay, the key word here is except. So what is midface deficiency? So it is generally associated with class 3. Midface deficiency. Those are the maxilla is retrusive. So for class 3, we usually give Frankel 3 and activated 3. It denotes the class 3 mallocclusion. And face mask is also given for bringing the maxilla forward. So the answer would be chin cap. Some rare scenario, chin cap can be used whenever there is a mandibular prognathism. But here the question was maxillary or midface deficiency. So chin cap would definitely be an answer. So this is a case of maxillary retrusion. See here, maxilla is actually behind because of reverse overchin. What will happen after the face mask? It has come forward. See the profile difference. So this is the case of mid-face deficiency. Can you see the mid-face deficiency here and the difference between here and here? That is the answer. So this Frankel 3 or activator 3, generally when it comes to functional appliances, activator or Frankel is commonly associated with which type of mallocclusion they are going to be treated. It can either be Frankel 2, different types for class 2, and Frankel 3 for class 3. Similarly for activator 2 or activator 3. When protraction headgear was used, most of the orthopedic changes are observed within the first. So, what is protraction headgear? So, they're talking about face mask. So, they're talking about face mask. Yeah? So, maximum most of the change will be seen in the initial 3 to 4 months itself, because if the patient is wearing the elastic properly, and we can elicit a major change the first 3 to 4 months. Because later which the bone will be forming and it will take up to a year for the bone to form completely and to discontinue the appliance. Regular monitoring is also required. The amount of force to be applied by the chin cap to stop the mandibular growth. So chin cap is generally used in class 3, but most probably it is associated with mandibular prognathism rather than maxillary retrognathis. So what will be the force there? It is around 1000 to 1200. So what was the other value that we recently read? Headgear, what was the force given? It is between 200, 100 to 200 on per side. Should always remember that. And when it comes to chin cup, a lot of force extra is given in order to prevent the further growth of mandible, and that's why it is 1000 to 1200 grams. Amount of force required to effect the mandibular changes at the condylar region. So, mandibular changes generally occur by the forward or downward or forward or the upward direction of growth, right? So, what will happen when we do a tensile force or tensile direction of the mandible? The bone will get formed in the condyles. That is how the whole concept of functional appliance works. We are just pulling the mandible forward. With this tensile force, some osteoblast is getting deposited on the condyle region, which will help in the elongation of the mandible, and the mandible will acquire a more forward direction, right? So this is the concept of functional appliance. So what are they asking for us is that amount of force required to effect the mandibular change in the condyle region. So what will be the force required? It is 4 to 5 gram per centimeter square. So if that much of force is given, then it will produce some change in the condylar region. So to answer it, it's 4 to 5 grams per centimeter. So that much amount of force is required. So today we are dealing with a lot of numerical values. So it will be good if you take it all down and note it in a together so that you can compare. So we obviously know that headgear for maxilla is very much more like 100 to 200. For mandibular prognathism, it goes up to 1000. But for condylar movement or mandibular change, you need only 4 to 5 grams per square millimeter. So when you note them all together, it will be very easy. If the following are true of chin cap, it has to exert 2 to 3 pounds if worn for 10 to 12 hours. It has to exert 1 to 2 pounds of force if worn for 16 to 18 hours. It has to be worn for 24 hours per day to correct severe prognatic mandible, all of the above. So chin cap, it actually does everything. Because chin cap, we provide a lot of force, like 1000 grams of force, right? So it has to be depending on the number of hours it is worn, the force exerted will be more. So let us now understand why all of the statement is true with respect to chin cap. it has to exert 2 to 3 pounds of pressure. So the pressure which is exerted by the appliance is worn for 10 to 12 hours. It also needs to exert a force of 2 to 3 pounds when worn for a duration. This force level is carefully determined by the orthodontist. So when worn for a longer duration of force, okay, if the patient is wearing for 10 to 12 hours, right? So we have to give the necessary pressure so that within that period, the pressure is being delivered. If the patient is wearing for a longer duration of time, then the initial pressure can be reduced a bit so that the optimum pressure is reached when the patient is reaching a period of 16 to 18 hours. So basically, see, if you're going to, I'll provide you the easy example. So you have to read 10 chapters. So if you want to write exam in 2 hours, then you have to read 5 chapters in 1 hour and the 5 chapters in the next hour, right? But if you have 3 hours for the exam, you can divide that chapters. You can reduce the chapter for each hour. So that's what happens here. So when the duration of wear is more, the pounds which is given initially getting reduced because it is going for a long period of time. Don't confuse yourself in the other way. So when he wears almost all the time, then obviously the force which is given to him is going to be less because it is being used for a longer period of time. That's why the answer is all of the above for this question. See, the pound value has reduced when the duration has increased. So that's how it works. Occipital pull chin cup is frequently used to treat class 2 skeletal cases, mild to moderate mandibular prognathism, maxillary prognathism, or class 1 skeletal cases. So it is something occipital pull. So occipital pull is also there and chin cup is also there. So in occipital chin cup is an orthodontic appliance which applies force to the chin area, exerting a backward and then upward force on the mandible. So it is actually redirecting the growth and development of the mandible. Whenever chin cup is associated, it is concentrating only on mandible, and that too in the class 1 cases. So we have seen a mostly about class 3 case when it comes to petit face mask or protraction headgear. But chin cup is usually associated with the mandibular prognathism alone. So when they are combining with occipital and chin cup, so that combination is usually occurring in treating the skeletal class 1 cases. So that's why this combination you should understand is used for skeletal class 1. Why they need to use that to modify the growth pattern of the mandible by applying a backward and an upward pressure on the chin, they tend to modify it and thereby bringing it to a proper position. So yes, with that we come to the end of today's discussion. Yeah. So if any of you have any questions, kindly ask me. Okay. So if you have any questions with respect to orthopedic appliances, what is face mask and what is headgear, then kindly let me know. I can address in the next session. Thank you and have a great day.